has to do with uh, attorneys' offices kind of soliciting clients for a class action lawsuit for Elmiron-related maculopathy. And I wanted to tell you our story behind this. And so we're going to talk about Pentosan polysulfate maculopathy. This is a drug also known as Elmiron. These are my learning objectives, my disclosures. I have none. And I'll start with this case. This is a 61-year-old lady I saw a couple years ago who came to me with a diagnosis of pattern dystrophy. And the story didn't quite fit. She had no family history. Her genetic testing was unremarkable. And when I looked at her medication list, she was on this drug, Pentosan polysulfate. And it brought to mind some other patients that I had seen with similar findings who were also on this drug. So I went to Emma. They have this advanced patient search feature. I punched in the name of the drug and my name and hit search. And this is what I came up with. I had seen 6 patients over the last couple of years who had similar fundus findings, all who had been on this drug for a long period of time. I teamed up with our fellow at the time, Will Pierce, who put this paper together in ophthalmology, and he described our findings of this new macular disease. So what is this drug? Pentosan polysulfate is a macromolecule resembling glycosaminoglycans. It was FDA approved over almost 25 years ago now for this condition called interstitial cystitis. This is a condition involving bladder and pelvic pain, and it's estimated that over 1 million US adults are affected by IC. Indeed, this drug has been used across the globe, actually since probably the early 80s for this condition in an off-label fashion. And the approvals started coming in the early 90s for this indication. So we felt like this was a notable finding, and we wanted to make sure we presented our findings properly and proceeded properly, and we knew there were going to be some medical legal implications, and so I wanted some help to make sure I did this right, and I enlisted the help of Dr. Fernandez. And Dr. Fernandez is he's older than he looks, actually, and he has a lot of friends here at Emory, and this isn't exactly what he said, but I'm paraphrasing. He put me in touch with the right people in the compliance office, the IRB, the legal counsel here at Emory to make sure we did everything properly moving forward. We filed a report with the FDA's MedWatch. We engaged the drug manufacturer to kind of make sure that they're aware of these findings. And then we wanted to do our due diligence to make sure that we weren't making a mistake here. So this first case I presented, and this lady, she was on this drug, PPS or Pentosan polysulfate, for this condition, interstitial cystitis. She also was on a number of other medications. And so how could we be sure that it was the drug itself that was causing this condition and not one of these other medications or this condition IC itself? Next, we went to our medical records and looked at all patients seen at the Emory Eye Center with a diagnosis of interstitial cystitis. We just pulled a list by ICD code. We had 219 patients who had been seen here at Emory, at the Emory Eye Center, and we had masked readers going through their fundus images to see which ones had these unique macular changes. The readers had no idea what drugs these patients were on. And this was Adam Hanif's project. Adam is now a resident at OHSU, former Emory medical student. And what he found was that the only risk for developing this maculopathy was exposure to this drug, Pentosan polysulfate. In fact, there were no cases in patients who hadn't reported taking this medication. So now we wanted to expand our study and go outside the borders of Emory to access more patients with interstitial cystitis. We teamed up with the Interstitial Cystitis Network, which is a patient support group online, and we were able to quickly access a large community of people suffering from this illness, and we performed an IRB-approved online survey with this patient group. It was a short 5-minute survey, And we had about a 14% response rate, which is actually pretty good for this type of email survey where you're kind of cold emailing a bunch of people who don't know you. And we had nearly 900 people with interstitial cystitis participate. And by doing this, we were able to get some interesting information, including patient-reported outcomes directly from the patients. I'm just going to highlight a couple findings. This is Ole Uner's work. He's a medical student here applying for ophthalmology this year. And what he found was that when we asked the question, have you seen a retina specialist in the past 5 years, the people in the high exposure group who had reported high exposure to the drug were significantly greater risk of having seen a retina specialist and having been diagnosed with a maculopathy. Again, that study also allowed us to query some patient-reported outcomes, which is a kind of unique feature of a patient survey like that. Next, we went to a claims database, and in this study, we did not have patient-reported outcomes, but we had much greater numbers. And we looked at a claims database of a large US national insurer that had 90 million enrollees. And we looked at people who started taking this drug, and then we evaluated their ICD codes 5 years later and 7 years later to see if there was an increased risk of macular disease. And this is Alexa Lee's work. And as you all know, Alexa is a retina fellow out in California now. And what she found was that there was a trend for increased odds of a macular disease at 5 years and a significantly increased risk of macular disease at 7 years. And the odds ratios are a little smaller here, and there's reasons for that, which we can go into greater detail if anyone wants to talk about that. But there was a kind of what appeared to be a dose-response relationship here. We wanted to hash out in a little more detail the fundus findings to help people discern what's really PPS maculopathy versus some other disease. And so we teamed up with 4 really outstanding retina centers around the country to identify cases. And this is another project from Adam, who looked at 35 people with this new condition. The median age was 60 years. The most common presenting diagnoses were AMD and macular or pattern dystrophy. And I think this is really important. You know, this drug has been around for decades, and this new entity was only described a couple of years ago. And one of the questions is why? And I think part of it is that it's a masquerader, and it's been kind of misdiagnosed as AMD and pattern or macular dystrophy for some years now. In this group of patients, the median duration of intake of this drug was 15 years. So it's really long-term use of this drug that leads to this condition. The median acuity was not bad, but these patients had really bothersome symptoms. They really struggled with reading, with adjusting to dim lights. This is a life-changing diagnosis for most of these patients. We looked in great detail at their fundus imaging to describe the phenotypic spectrum of this condition. And I'll just highlight a couple findings. One is that the fundus findings are actually quite subtle, but when you look at fundus autofluorescence imaging, they're really quite dramatic appearance. In 40% of the subjects, we identified macular atrophy, and in some of those cases, it involved the center of the macula. And this is reminiscent of geographic atrophy that we see in AMD, which can really have a significant impact on our patients' activities of daily living. In this case, we characterize how dynamic this disease process is. You see how rapidly it progresses from the time of onset. So it takes years to get to this stage that we see on the left here. But in this particular case, once the disease started, over an 8-month time frame, we see pretty dramatic evolution of this disease. Well, we wanted to help clinicians better discern the difference between this condition and macular and pattern dystrophies. When these patients come to our clinics, it can be often hard to say for sure if we're dealing with a hereditary process or a drug-related process. And this is our former fellow, Alex Barnes' project. He's now practicing in Florida. And he and a medical student looked at over 1,100 charts in a masked fashion to see if they could tell which cases were PPS maculopathy and which ones were hereditary. And so these charts were all pulled based on the diagnosis code of hereditary maculopathy or pigmentary maculopathy. And Alex crushed it. He had 100% sensitivity and 99.6% specificity. In fact, he did so well that I was a little worried that it would raise some eyebrows. He did too well in determining the difference between these conditions. One of the key findings that he really delved into was this finding of the peripapillary autofluorescence pattern. In this drug-related condition, which is the top left, there's this kind of dark halo around the optic disc, whereas in most hereditary processes, it is relatively spared autofluorescence signal. The other condition we wanted to differentiate this from was age-related macular degeneration. In this demographic group, the most common cause of blindness is AMD, and again, many of these patients were previously diagnosed as having AMD. And our former fellow, Joseph Christiansen, who's now in practice in Texas, really found that the OCT findings are key. And he elaborated on this finding of the bottom image here being age-related macular degeneration. They have these RPE lesions that we call drusen, and really it's accumulation of material underneath the retinal pigment epithelium between the RPE and the Bruch's membrane. Whereas in PPS maculopathy, which is this top OCT scan here, you have lesions that appear to be within the retinal pigment epithelium itself, and they cast a shadow onto the underlying choroid. So what happens when patients stop taking this drug? The hope is that perhaps the disease process will slow down, or perhaps people will get better. And Rachel Shaw looked into this in great detail, and I'll play a video for you. This is a fundus autofluorescence image of a patient with PPS maculopathy. And here, this is minus 8 months before they stopped the drug. I want you to pay attention to these areas of RPE atrophy here, which is, again, akin to geographic atrophy. And as the video plays, over time, this is 4 months after they stopped the drug, and 11 months after they stopped the drug, you see these areas of atrophy continue to grow. Now this here, these areas are cause a pretty deep scotoma for the patient. This is the foveal center right here, and so it's quite alarming to see these areas of atrophy grow and encroach on the foveal center in this 61-year-old lady.
Dr. Primo was asking if also in addition to visual acuity, if I look at contrast sensitivity or any other metrics which may kind of explain this.
Right. So we have a really good question from Sue Primo about looking at other modalities to assess visual function like contrast sensitivity. And I'm going to get into that shortly, actually, with work that our future resident Riley Lyons has done. Again, so this is Rachel's work that was recently published in JAMA Ophthalmology. So Sue has queued it up perfectly for us. So we wanted to look in greater detail into the functional impact of this condition. Because if you're starting a patient on this drug and you're going to tell them, well, you might get this macular disease, but most people still see 20/20 or 20/25, are they really going to not want to take this drug? This drug, by the way, is the only FDA-approved oral therapy for this condition. And so we really want to be able to better relate what are the actual functional consequences of developing this condition. So we did a prospective study where we enrolled 13 people who had PPS maculopathy and performed a battery of tests over a 2-day period, and that we're going to continue for another 4 years. Some of the tests that we did include electroretinography. We did microperimetry, dark adaptometry. This is a dark adaptometer that was is on loan to us for this study from the company. We did ETDRS refraction and visual acuity. And we did do Pelley-Robeson contrast sensitivity. We did visual function questionnaires, including a low luminance questionnaire and National Eye Institute VFQ 25. And I'll briefly get into some of those findings. This is a microperimetry image. And what this shows us is that the mesopic macular sensitivity is actually not bad in most people with this disease. However, if you have a patient with areas of atrophy, and I'm trying to outline this area of atrophy for you here, the sensitivity is basically zero. We get kind of the floor effect there. So this is under mesopic lighting conditions. It's mainly the areas of RP atrophy that lead to profound scotoma. We were fortunate enough to get a donation of a device that does scotopic microperimetry, and that'll be a next step for us to see scotopic under dim illumination what the macular sensitivity looks like. And that device will be used for studies in age-related macular degeneration as well. So I just want to show this figure just to show the amount of work that Judy Brower and Riley Lyons have put into this study. I'm not going to go into great detail here, but this was, again, Riley is an incoming ophthalmology resident doing his transition year here. And what he found that for most modalities, he was able to correlate functional impact of this condition with structural changes in the retina. In this one test, the low luminance questionnaire, the patients in our study had the lowest scores ever reported using this instrument, to our knowledge. And so many thanks to Judy and Riley for their great work on this. And this paper has had some great reviews in a top journal, and hopefully will be published soon. So the last thing I want to show is a case report by Josh Barnett of new onset disease after stopping the drug. And when I tried to find a mugshot of Josh, this is what I came up with. And I was thinking, surely our Josh Barnett doesn't do mixed martial arts. So I Googled more specifically. I said, Joshua McAllister Barnett, MD, PhD, Emory, Retina, and I still got this image. And so I was really puzzled, but then it hit me, this guy's the wrong size. Our Josh Barnett is much bigger, and fortunately these figures are to scale here. And I'll tell you a little bit more detail about what Josh described. He has this case of a patient who came to us with PPS maculopathy, and her symptoms started 3 years after she stopped taking the drug. The question was, did she already have it before stopping the drug, and maybe wasn't symptomatic, or did she actually develop this potential toxicity years later? Well, we were able to track down fundus images taken by her optometrist several years prior when she was still on the drug. And if you look very closely here, you might be able to find some subtle, changes, but nothing that really looks exactly like PPS maculopathy, and certainly a lot different than what we see here 3 years later. Unfortunately, we don't have comprehensive multimodal fundus imaging from the optometrist at that time, but this is highly concerning. Would you want to be on a drug that could potentially cause vision loss years later after you've stopped taking it? I think this could be a game changer, and so we need to explore this further, but this report has been well reviewed, and hopefully will be in print soon. So take-home message, this long-term use of this drug is strongly associated with a vision-threatening macular disease. It masquerades as AMD or pattern dystrophy, and it may progress after drug cessation. I want to thank our funders and also our team of our clinician investigators here, Ben Meyer, a current Emory medical student applying for ophthalmology residency, Aaron Lindecki-Myers, similarly a talented Emory medical student applying for ophthalmology resident, and you all know Albert. Special thanks to our photographers here. A lot of our work has really been imaging heavy, and we are blessed to have a good photography group and technology to be able to really illustrate this condition in great detail. And I'll take questions.
Do you think
Dr. Hubbard.
this, do you think these patients who are treated with this drug should have systematic screening?
Yeah, so Val asked a great question regarding screening. Should these patients have screening if they're on the drug? And we